A very good afternoon, everyone. I will be speaking about, I'll be giving you an overview of abdominal imaging. We'll start from fundamentals and try to reach to recent advances in the 10 minutes that is provided. So when we speak of abdominal imaging, like we use the whole gamut, like what is available, plain X-rays, ultrasound, CT and MRI. Each has its own advantages and disadvantages, which have been already spoken upon eloquently by other speakers. So I will not be, going into that. Now, it is a vast area, abdomen, and I thought we would, classify abdominal imaging as structural imaging and advanced imaging. So by structural imaging, what do we mean? Like we just look at the size of structures, how big they are, whether they are enlarged compared to normal, or are they contracted. So this is the basic, most basic level of imaging that we can do, and that is what we do day in and day out. This is the bread and butter of radiology. So what do we look for in structural imaging in radiology? We look at enlargement of solid viscera, dilatation of hollow viscera like the bowel, enlargement of nodal tissue, ductal dilatation and vascular dilatation or narrowing. So this is generally what we do. Just look at whether the organ is enlarged or reduced in size, whether a duct is enlarged or reduced in size, or a blood vessel is enlarged or reduced in size. This is the basic imaging that we do. And for that we use all the modalities. One is the historically used X-rays. X-rays are now more of a screening modality. They are not used for definitive diagnosis because, as you can see, obviously this is a X-ray of the abdomen which is showing an enlarged liver, but it isn't obvious. Like if I maybe draw a line showing that this is a liver, it becomes obvious. So X-rays lack inherent contrast resolution in the abdomen because almost all the abdominal structures have a density which is very near fluid. So differentiation on X-ray is very difficult. So what comes to our help is ultrasound. Here you see an ultrasound picture showing the liver which is enlarged. When the lower edge reaches below the level of the kidney, we consider the liver enlarged. This is a picture taken of the spleen which shows an enlarged spleen. So and the same thing seen on CT here, an enlarged liver here and an enlarged spleen. Now what is the advantage of CT over ultrasound? One is CT does not have operator dependence. One problem with ultrasound is that it is heavily operator dependent. So ultrasound results depend on the person doing the ultrasound. So this kind of operator dependence is a negative point for ultrasound, and CT overcomes that. Also, deeper viscera like the pancreas are more commonly not seen on ultrasound due to shadowing by the overlying gastric gas, and this is overcome on CT. So this is the basic difference between ultrasound and CT in the abdomen for picking up visceral enlargement. Now talking about hollow visceral issues, bowel dilatation. Classically, X-ray has been the mainstay of diagnosing small bowel obstruction. Even today, X-rays are used to diagnose small bowel obstruction. You diagnose it by seeing fluid levels on the erect abdominal X-ray and by seeing dilated bowel loops on the supine abdominal X-ray. This is used for diagnosing small bowel obstruction, and the supine view is used to differentiate whether the bowel is small bowel or large bowel, depending on the picking up of valvular conjunctivitis or the absence of it. We differentiate between small bowel and large bowel obstruction. But what is the biggest disadvantage of this? This is very useful, but still it doesn't tell you certain things. One is it doesn't tell you what is causing the obstruction, and second, it does not give any information about the wall of the intestine. So it gives you luminal issue. Same issue with barium or contrast studies of the abdomen, not used anymore, not done very frequently anymore. This is an enteroclysis. This also shows the lumen to very good effect. You see the mucosal detail and the valvular conjunctivitis very nicely, but what you do not see is important. is that it does not give you any information of how the wall is. So that is where CT comes in and ultrasound comes in. So ultrasound and CT give you much more information in that they also tell you about the cause of obstruction. Is there a malignant tumor causing the obstruction? Is there a stricture causing the obstruction? Ultrasound is more useful in picking up tumors causing obstruction, whereas for strictures may be difficult, but it still shows you the dilated bowel and the valvular convent is here. This is the dilated small bowel in ultrasound, and this is a CT picture. So CT gives a much more panoramic perspective of the abdomen. It not only diagnoses the small bowel obstruction, it gives you mural information. You can see the wall very nicely here, and it also gives you whether it is a malignant tumor that is causing obstruction, or it is an adhesion, post-op adhesion, or it's a closed loop obstruction or an open loop obstruction. All these details are given by CT. So that is the advantage that CT has. So this is the case. You see the CT shows exquisite mural information, thickening and stratification of the small bowel. This is a case of Crohn's disease. And this is the same CT in a different person. This is showing the stomach, and you can see the normal wall of the stomach, and this is the thickened nodular wall of the stomach. This is a case of carcinoma stomach. So that is the advantage of that CT has. What does MR have in hollow visceral issues? The same detail MR also can give. It gives exquisite detail about the wall. This is the T2 weighted image. This is the T1 contrast image, where you can see wall enhancement very nicely. So what is the advantage of MR? One is that there is no ionizing radiation. When does this come into play? When you have to do multiple studies, serial studies. When a person has a chronic disease like inflammatory bowel disease, especially Crohn's, and they are in the younger age group and they need follow-up, then you need MRI. You can do serial studies and yet not give the patient radiation and cause problems later in life. So there is the advantage of MR. So coming to lymph nodal enlargement, that is the next thing that we see. Solid visceral enlargement, hollow visceral issues, then lymph node enlargement. You can see here that CT picks up nodes. This is a case of lymphoma having multiple abdominal nodes and axillary nodes. Now, is there a role for ultrasound in lymph node enlargement? Yes, but there is a rider there. We'll come to that later. This is a normal lymph node seen on ultrasound. You can see that it looks like a small kidney. It has a cortex and it has a small, hilum, which is echogenic. And this is a malignant node where you can see that the hilum is totally lost. So that is what is the advantage of ultrasound, is that it can differentiate between benign and malignant nodes based on hilar architecture. But the problem with ultrasound is it cannot reach deep into tissue. So retroperitoneal nodes which are covered by some large viscera, you cannot access. Whereas CT has that advantage where deep retroperitoneal nodes can be seen, and in addition, CT also, if you give contrast, can pick up necrosis in the node. Now, why do you want to pick necrosis in the node? Necrosis points to mostly an infective etiology, mostly I say, not always, and is an important factor in diagnosing tuberculous lymph nodes, which is an important issue in our part of the world. Then we come to vascular dilatation. Contrast CT, that is CT angiogram, is the mainstay of diagnosing vascular issues in the abdomen. Here you see aortic aneurysm here, two cases, one and second. Two different ways of display are there. And also another case which is showing aortic stenosis here in a case of Takayasu arteritis. You can see that the CT angiogram gives a very panoramic perspective of the entire vascular system, especially in the abdomen. Now, we have advanced processing software for analysis of CT angiograms, where the blood vessel can be segmented and removed from the body, and the central line can be traced, and after that the whole aorta can be laid bare like this, leading to easy analysis of the entire blood vessel. And also by moving the markers which are here, you can readily measure the diameter and the stenosis, if any. This is a advanced vascular analysis software that is available now. Now, ductal dilatation. The most easy way to diagnose ductal dilatation, that is in the liver, ISBRD, biliary radicular dilatation, is ultrasound, but again it is very operator dependent. And CT reduces the operator dependence, but again it gives you cross-sectional images. You have to be familiar with cross-sectional anatomy to interpret the CT, whereas MRCP presents a much more familiar anatomic delineation of the ductal system. This anybody who knows anatomy can interpret. So that is an MRCP, and it is the mainstay of investigating ductal dilatation. Now, what can CT or radiology do apart from just structural assessment? It can also give you an idea of what material you're dealing with, especially identify air, fluid and fat. How does it do it? By measuring the CT value. So when does air become important in the abdomen? In the case of perforation peritonitis, this is an X-ray showing air under the diaphragm. What is the advantage of CT? This picture you will get only when significant amounts of air have entered into the abdomen. When minimal amounts have entered itself, CT will give you a diagnosis of pneumoperitoneum. Now the second important thing which you want to pick up is free fluid in the abdomen, and that is what free fluid looks like. Ultrasound is the mainstay of picking up free fluid. You can see a thin rim of fluid here in the Morrison's pouch between the liver and the kidney. So this is a CT image showing the same free fluid. How do you identify fluid? You measure the CT value, and if the CT value is in the 5 to 10 HU range, then you can assume that it is fluid. Now the third thing that CT can pick up is identify as material is fat. You can see that this is a lipoma in the abdominal wall. You can see that it is the same density as the subcutaneous fat and also the mesenteric fat. And how do you diagnose it? By measuring the CT value. Usually fat has a CT value around 50 to 60 in the negative range, 60 HU. So that's how you diagnose fat. Now what is the importance of fat in abdominal imaging? It produces inherent contrast. Fat is the packing material of the abdomen. It surrounds almost all the viscera in the abdomen. Kidney has perinephric fat, pancreas has pancreatic fat. Now by seeing whether this fat is normal or abnormal, you can predict the abnormal viscera. For example, you can see that this is normal peripancreatic fat, but this pancreas, you can see that the fat has increased in density. So by identifying this abnormality, fat increases in density because there is fluid inside the fat, and fluid increases the density of fat. You can interpret that there is something wrong with the pancreas, because all around the pancreas the fat is abnormal. This is the case of pancreatitis. Now this picture shows this is the right colon here, and this round thing here is the appendix. You can see that the periappendiceal fat has increased in density. So this is a case of appendicitis where you have edema around the appendix. Now this is all about structural evaluation and density basic material identification. Can you do more? Like the immediate tendency of a human being once you see something is to touch and feel it, right? So can you do palpation by imaging? Yeah, as it was already discussed, this thing is called virtual palpation or virtual touch imaging or elastography. So what we do here is I will be talking about one form of elastography, that is the acoustic radiation force impulse, RC dynamic elastography. There are different modes of elastography. So what happens is acoustic radiation force impulse is generated from the ultrasound probe. We need special probes for that, and that distorts the liver tissue. This is a case of liver RC. So, and this produces compression and release of the liver. Now this compression and release causes a shear force inside the liver, and perpendicular to the direction of the impulse there are shear waves which are generated, and these shear waves are the velocity of the shear waves is proportional to the stiffness of the liver. So you measure the velocity of the shear wave, you get an idea of the stiffness of the liver. So here the velocity of the shear wave has been measured, and it is 1 meter per second, which is normal for a liver. So this gives an idea of stiffness of the liver, and you can diagnose cirrhosis with the help of RC. Now the same thing can be done with MRI. The same external pressure wave can be created, but the distortion caused by the wave can be picked up by MRI. and this is a wave image, that is, this is the distortion caused by the external pressure wave on the liver by MRI is picked up, and this has been used to calculate an elastogram. So you can see that this is a normal liver, has shear modulus is given in this bar. Here it has blue color here, which is low levels of shear modulus, whereas this liver has high levels of shear modulus. This indicates a stiff liver or a fibrotic liver. Now, when is this important? When the conventional imaging shows that the liver is normal. For example, you see these two MRIs. This liver and this liver looks normal on conventional imaging, whereas the elastogram is as different as night and day. This is a normal elastogram, whereas this is a highly fibrotic liver. That is the use of elastography, that even when in conventional imaging the viscera looks normal, it can be very abnormal on the elastogram. Now the different kind of imaging, next what we are going to see is application of external contrast. We are giving IV contrast and then trying to make out pathology. Historically, contrast has been used just to differentiate between vascular structure and non-vascular structure. This was because the acquisition time of CT only was very prolonged. Usually the acquisition time when I was a PG used to be around 5 minutes. So once you finish acquiring abdomen image, the contrast was washed out by then. But then advances in CT have now made it possible to actually track the washing in of contrast and the wash out of contrast. This has been done because of faster acquisition. Now we can acquire the entire abdomen in 20 seconds. So once you acquire a plain image, then you acquire the arterial phase after 20 seconds. After around 60 seconds, or 50 to 60 seconds, you acquire the portal phase, and then you acquire the delayed phase around 1.5 minutes. Now what is the importance of this? You can pick up hypervascular, that is arterial hypervascularity. In this modality is called triple phase imaging, and in this you can pick up arterial hypervascularity, and arterial hypervascularity is of very much importance in diagnosing hepatocellular carcinoma. Now taking this a step further, now we have perfusion imaging. Now we can acquire the entire liver in 1 second. So what this has led to is, you get one picture of the entire liver every second, keep on acquiring, so track the wash in of contrast and the wash out of contrast, and this is called perfusion imaging, and this data set can give us the calculation of the arterial blood flow, the portal blood flow, and the arterial to portal ratio. So all this leads to better diagnosis of liver malignancy, especially hepatocellular carcinoma. So this is a case where just to illustrate the importance of perfusion imaging, where the hepatoma has been embolized here using lipiodol. This looks normal. There is no abnormal tumor, that is a residual tumor that is seen. But in perfusion imaging, you can see that there is a small area of arterial hypervascularity. Now what happened was, they have followed it 1 month later, they have done a CT, and you've seen that there is a recurrence there. So you can see here how important perfusion imaging is, and it has a lot of future in hepatic vascular imaging. Now if the person does not have has altered kidney function, then you cannot use iodine based contrast. For that we have alternative. You can use microbubble contrast. This has a gas core of sulfur hexafluoride covered by a lipid monolayer, and that can be injected IV, and the tracking of contrast can be done by ultrasound. This is called contrast sonography. Now we have seen about basic material characterization, that is air, fluid and fat. We can do it advanced using dual energy imaging. That is, if you perform the CT at 2 different kilovoltages, it is possible to identify iodine and calcium and material like that. So what is the importance of identifying iodine? For example, this is the dual energy application. This is the contrast image. From contrast, using dual energy application, you can pick up the iodine separately. And once you separate the iodine, you will get something called an iodine map. And after acquiring the iodine map, you can subtract the iodine map from the contrast study and get a virtual non-contrast image. Now what is the use of doing this? you need not acquire a separate non-contrast image. Usually when we do abdomen, we acquire a plain image and then we acquire a contrast image. If you do like this and acquire a virtual non-contrast image, the dual radiation is avoided. Using the same dual energy application, you can also subtract calcium. When is this useful? This is a CT angiogram 3D reconstruction. You can see that the bone is superimposed on the vessel, but using dual energy you can remove the bone, and after that you can even fine tune and remove the calcium from the vessel and seeing only the lumen. This is another application of dual energy. And a third application is in the kidney to differentiate between uric acid and calcium related calculi. This has a bearing on treatment. If you have uric acid, then you have to take steps to control the uric acid levels, and also it can help you to tell whether your lithotripsy is going to be successful or not. So that will bring us to the end of my talk. Thank you very much for your patient listening.